There will be a gallop rhythm with a third heart sound. A new systolic murmur, if found, this can signify acute mitral regurgitation or ventricular septal rupture. On chest examination, crepitation might be found at the lung bases if there is pulmonary edema, or in severe cases, crepitations throughout the lung can be found. And also there can be an expiratory wheeze. Now, chronic heart failure. In chronic heart failure, the scenario is of a relapsing and remitting course with periods of stability and episodes of decompensation intermittently. Clinical picture will depend on the nature of the underlying heart disease, the type of heart failure which it has evoked, and the changes in the sympathetic nervous system and RAS system which have developed over a time. Low cardiac output causes fatigue, restlessness, and a poor effort tolerance. The peripheries are usually cold and the blood pressure is low. For maintaining the perfusion of vital organs in setting of low blood pressure, the blood flow is diverted away from the skeletal muscles, and this may contribute to fatigue and weakness observed in the patients of heart failure. Because of poor renal perfusion, there can be oliguria and uremic features. There can be pulmonary edema because of left heart failure, and the patient will present with dyspnea and inspiratory crepitations over the lung bases mainly. In contrast, the right heart failure patients, they present with a high JVP with hepatic congestion and dependent peripheral edema. In the ambulatory patient, this edema affects the anchors, which are the most dependent part in the ambulatory patient, whereas in bed-bound patient, the edema collects mainly around the thighs and the sacrum. There can be ascites or pleural effusion. Sometimes there can be marked weight loss. We call it cardiac cachexia. It is caused mainly by a combination of anorexia and impaired absorption due to GI congestion, along with poor tissue perfusion due to low cardiac output and skeletal muscle atrophy due to immobility. Here there is a diagrammatic representation of the various clinical features. On the left we can see left heart failure signs. There can be raised JVP, signs of pulmonary edema. There will be creps on auscultation. Then cardiomegaly, the peg speed will be shifted outwards. Then pleural effusion can be there, and pitting edema can be there. In right heart failure, this raised JVP and pitting edema are much more prominent, and there is no pulmonary edema but hepatomegaly we can find, and also there can be presence of ascites. Now, physical signs. Physical signs again can be divided into those because of left or right cardiac dysfunction, as we have already seen in the diagram. Common signs of left-sided heart failure include pulmonary rales, wheezing can be there. The intensity of S2, S3 is increased, or S4 gallop can be there. There can be mitral regurgitation murmur. The pulmonary rales result from the popping open of small airways which has been closed off by the edema fluid before inspiration. There can be cardiac asthma resulting from compression of larger airways. There can be an early diastolic sound, or S3, signifying increased left ventricular end diastolic pressure in the patients with decreased left ventricular function. There can be a late diastolic sound, or S4, which may result from forceful atrial contractions into a stiffened LV. The left ventricular dilatation can result in incomplete closure of the mitral valve during systole, and there can be a functional mitral regurgitation because of this. Common signs of right-sided heart failure. There will be distension of jugular veins, hepatic enlargement can be there, dependent edema will be there, then right ventricular heave or gallop we can get. There can be tricuspid regurgitation murmur. Signs of impaired peripheral perfusion, cardiac cachexia, diaphoresis, tachycardia, tachypnea, and narrow pulse pressure. These are often the signs of advanced disease. coming to complications of heart failure. The complications are renal failure, which is caused by poor renal perfusion because of the low cardiac output state. And this renal failure can be exacerbated by diuretic therapy, ACE inhibitors, and ARBs. So we should be vigilant and monitor renal functions while we are treating the heart failure patients with these drugs. Second, they can have hypokalemia, which can again be the result of treatment with potassium losing diuretics or hyperaldosteronism caused because of the activation of the RAS system and because of impaired aldosterone metabolism because of hepatic congestion. Most of the body's potassium is intracellular and there may be substantial depletion of potassium stores even when the plasma concentration is in the reference range. So this has to be noted. Sometimes there can be hyperkalemia also because of effects of drug which promote renal reabsorption of potassium. In particular, the combination of ACE inhibitors, ARBs and mineralocorticoid receptor antagonist. Okay, so potassium sparing diuretics, when they are used, sometimes there can be hyperkalemia also. These effects are amplified if there is renal dysfunction due to low cardiac output or atherosclerotic renal vascular disease. So, especially in these patients with renal dysfunction, we should be carefully monitoring when we are prescribing these drugs. Next complication, there can be hyponatremia, which is a feature of severe heart failure, and this carries a poor prognosis. This hyponatremia can be caused by diuretic therapy. It can be because of inappropriate water retention because of the high vasopressin secretion, or it can be because of failure of the cell membrane ion pump. Then there can be impaired liver function caused by hepatic venous congestion and poor arterial perfusion, and this frequently causes mild jaundice and abnormal liver function tests. There is reduced synthesis of clotting factors which can make anticoagulation control difficult. Then the complications may include thromboembolism, deep vein thrombosis and pulmonary embolism. This can occur because of the effects of low cardiac output and enforced immobility. Then systemic emboli can be there, especially in patients with atrial fibrillation or flutter, or in patients with intracardiac thrombus complicating conditions such as mitral stenosis, myocardial infarction or left ventricular aneurysm. Then there can be atrial and ventricular arrhythmias. These are very common and these can be related to electrolyte changes such as hypokalemia, hypomagnesemia, also because of the underlying cardiac disease and the pro-arrhythmic effects of sympathetic activation. Atrial fibrillation occurs in approximately 20% of the patients with heart failure and causes impairment of cardiac function. The ventricular ectopic beats and runs of non-sustained VT can be there. Sudden death can be there in up to 50% of patients with heart failure, and this is most probably due to ventricular fibrillation. Coming to diagnosis. Routine lab testing. So we'll send complete blood count, serum electrolytes, blood urea nitrogen, serum creatinine, hepatic enzymes, the urine analysis. Then selected patients, they should be assessed for diabetes mellitus, dyslipidemias, thyroid abnormalities. Then all the patients, a routine 12-lead ECG is recommended to assess the cardiac rhythm. Also it will show, give an idea about the presence or absence of LV hypertrophy. Then signs of prior myocardial infarction, that is presence or absence of Q waves or ST changes. Then also we can determine QRS width to ascertain whether the patient may benefit from resynchronization therapy. A normal ECG virtually excludes LV systolic dysfunction.